Good afternoon, and welcome to Westfield State University's Community Conversations. I'm Dr. Linda Thompson, the 21st president of this incredible university, and I'm pleased to welcome you to this discussion. Over the next few weeks, we'll be hosting a total of 4 community conversations on a variety of topics of local and national interest. We'll be looking into equity within the criminal justice system, how equal access to capital can create a healthier economy, and how greater equity can help us become a healthier society. I expect all of our community conversations to create meaningful and fascinating dialogue. Before I jump into today's topic, I want to thank those of you who have already submitted questions for our panelists. I ask those of you here in our studio audience to write any questions you have on the cards that you found at your seats and pass them to our assistants in the studio. Those with us virtually can put your questions in the chat box, and we'll do our best to get to as many of them as possible. For today's community conversation, our topic is health equity. I came to Westfield State with a deep background in public health, so I find our conversation today to be particularly intriguing. Recent years have brought increased scrutiny of our healthcare system and the overall health of our nation. While life expectancy in the United States has improved, that improvement varies dramatically depending on who you are, where you live, your income, your ability to access care, and a wide variety of other social, environmental, and economic factors. We'll be diving into each of those topics as best we can with an array of leaders in this field. Bringing us a national perspective today is Dr. Gail Christopher, who is nationally known as a leader in health policy. Dr. Christopher has served as a senior advisor and vice president at the W.K. Kellogg Foundation. She also chairs the board of the nonprofit organization Trust for America's Health. And in 2019, Dr. Christopher became the executive director of the National Collaborative for Health Equity. To bring a strong regional and local perspective to this discussion, we've invited Dr. Frank Robinson, Vice President of Public Health for Baystate Health System. In that role, Dr. Robinson is responsible for integrating clinical and community care to best serve vulnerable populations and to create healthier communities. Joining Dr. Christopher and Dr. Robinson is Tania Barber, President and CEO of the Caring Health Center in Springfield. The Caring Health Center is the only federally funded community health center in the city of Springfield. The CHC has 5 primary care sites throughout the region and employs 266 employees. They serve 28,000 patients with over 70,000 medical visits and 20,000 dental visits annually. Ms. Barber oversees the wide range of programs available at the center, which is designed to improve access to quality health care for residents in Springfield. We also have with us Dr. Jessica Grabowski, a valued member of the Physician Assistance Program here at Westfield State University, one of only a few physician assistance programs at a public university in the Northeast. Joining us as well is Regina Santana, a 2019 graduate of the Physician Assistance Program here at Westfield State. Regina currently serves on the staff at the Caring Health Center. Welcome, everyone. I want to begin this discussion and turn it over to Dr. Christopher.
Well, thank you so much for the introduction, for the invitation. And I'm so honored to be on this conversation with all these esteemed local leaders. It is absolutely my pleasure. Health equity is the topic of the day right now. I started my morning with a conversation with the Association of State and Territorial Health Officers, and I'm always reminded of the stress and the trauma that the healthcare system and the public health system has experienced as we've attempted to lead and navigate through these amazing last 2 years of the COVID-19 pandemic. And so I am always happy to start and end my day in conversation. This particular conversation is community focused and community based. So it gives me a great deal of pleasure to interface with all of you.
Well, why don't you bring to us a perspective of what you see happening at the national level around the health issues facing communities of color and vulnerable populations of citizens in the United States. And what do you see as programs that we need to be advocating for on a national as well as local level? And then I'll let our team here also pipe in on some of the things that they see we need to be doing.
Well, I'm happy to do that. Let me begin by saying that it is no secret that the diverse communities of color, whether they are indigenous Native American communities or communities living in immigrant communities, African American communities, low income communities, there is no question that the burden of COVID-19 fell disproportionately on these communities. And as you talked about life expectancy, Doctor, I was reminded of the fact that we actually lost progress. We actually went backwards in terms of life expectancy outcomes amongst communities of color as a result of COVID-19. So there is no question that our communities experienced a disproportionate burden, and those of us in the field predicted that at the outset of the pandemic. And largely as the evidence became clear that those with chronic disease conditions, including obesity and other challenges, that they would be at greater risk, at greater vulnerability for serious conditions and for actual mortality. But we also know that the social structure of our society created disproportionate exposure through the work and through the communities and the housing. So we really got a chance to see how the social determinants really do predict and determine health and well-being during this pandemic. So when we talk about the programs and policies that our country we all should be advocating for, after many, many decades of work on health equity and well-being, I finally just realized that the unfinished business of eradicating racism in this country, it's really the critical effort that we need to make. Because if we could learn to see ourselves in the face of one another and to truly see and value one another as full, equal human beings, we would collectively stand for the policies and practices that we need to put in place to create optimal social determinants. We talk about social determinants of health, but we're really talking about social determinants of disease more than health. But we know, and at our organization, the National Collaborative for Health Equity, we have put in place an interactive website for measuring the data that tracks the indicators of the conditions that are necessary for achieving health equity. It's called the Health Data Initiative, and we really do play on the words health, opportunity, and equity in calling it a Hope Data Initiative. But we know that if people have a living wage and if they have affordable housing, if they have access to post-secondary education and gainful employment, if the air is breathable, we know that these are the conditions that promote longevity and well-being. And so these are the types of actionable items that we need to be standing up for in our community. And the Hope Data Initiative allows states and locales to say, you know, if 500,000 more people had access to a living wage, we'd be that much closer to achieving health equity. If 300,000 more people had access to affordable post-secondary education or affordable housing, we would be that much closer to achieving health equity. So we really believe it's time for us as a country to not just give the statistics and the inequities and the disparities, but to actually put in place the advocacy. We are a democracy, and let's face it, nothing happens if we don't organize and advocate for it. And so it's time for us to start to recognize the true connection between the social factors and the opportunity to experience health, to experience well-being. So that's my basic statement about the things we should be standing up for. Should be standing up for equal opportunity to experience the conditions that we know reduce stress at the individual and the community level. We also know that this exposure to violence, the violence in our communities, the gun violence, we know that that has to be addressed. And we have to get our arms around that and turn that back, because it is far too much stress and too much needless loss in our society. So I definitely think and am very proud that we are saying to the world, let's advocate for creating the conditions of health and well-being.
Sure, everything you just said is so critical for all of the programs that we're offering in our communities. I just want to turn to Dr. Robinson and ask him to weigh in on what we are trying to do here in the Pioneer Valley through Baystate Health to try to promote health equity. And what do you see as some of the issues right now here in our region, and what we can be doing?
Well, let me respond in two parts. One is the Hope Data Initiative informed our current community health needs assessment process. Every 3 years, hospitals in the nation have to complete a comprehensive health needs assessment. We're in our third 3-year cycle. We formed a hospital coalition here in Western Mass where hospitals work together to do a comprehensive regional assessment. And we typically measure illness or health problems. And we've been pushing to determine, well, how do we figure out whether or not we've made a community impact that actually delivers us or moves us towards equity. So we use the Hope Data Initiative and the National Equity Atlas put out by, can't remember.
Policy Link.
Yeah, thank you.
Yeah.
And we use those two documents to sort of inform our work. And so we have a team that's trying to cobble together a set of indicators that will allow us to evaluate whether we've made a difference. So every 3 years we do the assessment, then we're supposed to check and whether we've made any improvement and whether we've made an impact on community. And so this year, moving into our next 3-year cycle, we hope to have some community impact indicators fashioned off of the work of the Hope Data Initiative that will allow us to see, have we moved the needle in the right direction towards equity. So that's a concrete example of what's happening in this region, linked to us, a project that you're leading nationally.
Yeah, one of the things I just wanted to ask you, Tania, is first of all, could you share with the audience here what a federally qualified healthcare center is? So,
Sure.
I mean, that's a mouthful, but from a treatment level or a health center level, what is it that you're trying to do to take the data and try to improve health outcomes for the people who choose to come to your clinic?
Sure, thank you. So for the first part, for the first question, Caring Health Center is a federally qualified community health center. So unlike Baystate, who owns health centers or community health centers, we are actually funded through the federal government, and we have to apply every 3 years to maintain our funding to remain as a Section 330 federally qualified community health center. So essentially a portion of our dollars come through the federal government, and then of course the other percent comes through third-party billing, through insurances. And like Dr. Robinson, one of the things that Caring Health Center has done for well over 20 years, and this is unusual for a community health center, for 20 years we collaborate with the community with research-led initiatives, and then we look at the data. So we look at REL, race, ethnicity, and language, to inform best practices, to come up with interventions, because Caring Health Center is also the largest refugee provider in the state of Massachusetts. We serve in over 30 different languages, so it's imperative that we understand the population that we serve and that we are looking at the data to inform practices. And that was one of the reasons why we developed a robust research at Caring Health Center, and we have an epidemiologist at Caring Health Center who reviews our data, and then of course working with Baystate and the Accountable Care Organization, collaborating, looking at the CHNA data, looking at our data, and then ways that we can improve healthcare in the community.
Wonderful.
Yeah, I just, I've always been in awe, and the federally qualified healthcare center movement started here
Yes.
in the Commonwealth of Massachusetts. I just want to share with that, and they led the nation on this. But I just wanted to turn to one of our faculty members and say, how are you using data to begin to develop the future healthcare provider right here on our campus?
Oh, absolutely. So as stated at our introduction, the Westfield State Physician Assistant Program is one of the only public university PA programs, as well as the only public university program here in New England. So when we look at our community data, who is our community? Who lives here? Who needs the most health care? What issues do these different populations struggle with? We really do our best to include that in our curriculum, and especially in our recruitment of our future healthcare providers. So always room for improvement, but our current matriculating statistics are that we recruit diverse populations 3 to 4 times the national average for PA programs. Really trying to start our solution here locally in the Commonwealth and beyond.
And I'm exactly an example of that.
An example of one of our student graduates.
Absolutely.
Here.
Dr. Hitton said, Regina, just talk about your experience as part of the PA program and as part of the staff at Caring Health Center. So just a little bit of background. I'm coming from Dominican Republic, and I had the opportunity to come here, have my family, but in my country, I had the opportunity to do general medicine for 5-6 years. I was working there for 3 years in a dialysis unit, so coming in here was a huge change for me. It was like starting from the beginning. So when I was looking, I was like, I need to continue helping patients. I need to continue, helping others in health area. So when I came here, that's when I learned about Caring Health Center. And they opened their doors for me, and I started working there as a patient care coordinator. But looking at the community, I was like, I know I can do more for my community. I want to be a provider. I was trained to do that. So working there, I knew about the PA program. And I talked to my supervisor, what do you think about the PA? And he said, that's a great idea. You're gonna have the opportunity to continue seeing patients, to help them. So I started applying to different PAs at school. And a few months later, I received a call from Professor Jessica right here saying, Regina, you have been selected to be part of the first graduating class from Westfield State University. Wow. And that was like huge honor for me because 600 applicants were there, and that was like an answer to my prayers.
Oh.
And I'm really grateful for Westfield State University and really grateful for this program because they were there for me. They support me, they encourage me. But let me tell you, it was not easy. It was not easy. When I came here, at the first day of the program, when I came back home, I came back crying, really bad. It's like I told my husband, hey, if I understood 50% of what the professor was saying was a lot. And he was like, what? Yeah, I did my background. It was in Spanish, so coming in here, as I said, was like starting over. But they were there for me, and they believe in me. And, here I am now. Here I am. And then I had the opportunity to come back to Caring House Center and continue serving the community as a PA now. And because they helped me, I'm there to help others. So this is a tremendous example.
Yes. Dr. Christopher, I know you are doing this work now at the National Healthcare Collaborative. What is it that what are all the things that you do as part of this to try to promote the health and well-being of people throughout the country? And what would you suggest to the audience and our team here about how we can get more involved in the work that you're doing to help you lead an effort nationwide to improve the health and well-being of people around the country?
Well, thank you for that question, but I must respond to the beautiful comments of all the panelists. It was so moving. I was so touched to know that our work has influenced your own initiatives and assessments in terms of the hospitals. And I have such deep regard for the community, the federally qualified community health movement. It's probably the best kept secret in America in terms of the opportunity for health and well-being. And you have a model there with the physician's assistance program, because one of the takeaways from the pandemic was the urgent need to diversify our healthcare workforce and to expand our healthcare workforce so that it is grounded in the real lived experiences of the communities that we serve. So your panel is good news, and it gives me a lot of hope for the future. So I wanted to give that feedback for sure. And the research, of course, that you do to document the effectiveness that you have with the community that you serve. It's just the perfect combination. We at the National Collaborative for Health Equity, we have three, I call them basic areas of focus. The first is developing leaders. We have a leadership program called the Culture of Health Leaders program, and we're launching a new Culture of Health Leadership Institute that is a shorter program. But we know, as you all exemplify, that this work gets done by people stepping into leadership and service roles within their communities. So each year, we bring in, each 18 months, we bring in a cohort of 40 people and take them through a very supportive experience. We also, in addition to focusing on leadership, I've talked about the data. The data is a critical part of our work. And then we are also, as you may know, I created a truth and reconciliation. We call it Truth, Racial Healing, and Transformation effort for our country before I left the W.K. Kellogg Foundation. And I promised as I was leaving that I would continue to be a champion for that work. And so, as I said in my opening remarks, we have to come to grips with the legacy of a past that denied the equal worth and value of all human beings. And so this Truth, Racial Healing, and Transformation effort is national in scope. It's happening in communities across America. And I don't know if it's possible to pull up that slide. I could go into some of the details of that on Truth, Racial Healing, and Transformation. It's a 5-part framework. And the first part of the framework for action is narrative change, right? How can we collectively tell a truthful and honest story about our history as a country? Every community has a unique history that's been rooted in some ways in the benefits of or the realization of the enslavement experience. We've had immigration policies that have been grounded in the same false ideology of a hierarchy of humanity. So being honest and embracing our history, both the good, the bad, the amazing resilience. That's what we mean by narrative change, which is the first pillar of the TRHT framework. But then, and this is the hard work, this is the work that we need more leadership, we need more creativity. We call it racial healing and relationship building, but we've got to call people into this work. And even Abraham Lincoln commented that you have to have public sentiment in a democracy in order to accomplish anything. So this work of healing communities, of building bridges, of overcoming polarization and divides, it's real work that requires empathy and compassion and understanding to really change the consciousness of people in terms of our preconceived notions and prejudices and misconceptions about each other. So the second pillar is really doing that work. And then finally, as we build our critical mass of engagement and we begin to have a collective narrative that we own of our history, then we can address and redress the legacy of the ideology of a hierarchy of human value. And that legacy, we think, has shown up basically through three primary means, and those are the final three pillars of the framework. One is through separation in its myriad forms, not the least of which is residential segregation, and school segregation, and the list goes on, but also through legal policies and practices and systems, part of which is the criminal justice system and its inequities, but our voting systems, our immigration laws, all of our policies grew out of this hierarchy, and they're embedded in state constitutions across this country. And then finally, the final pillar is the economy. And we have to work toward a just and fair economy. And actually, our healthcare system is the driver right now of our nation's economy. So we have to look at the tremendous opportunities that are embedded in this economy, not the least of which is the workforce and diversifying the workforce. So those are the 5 pillars of the framework for TRHT. And I can say it is a national movement right now. It's the only truth and reconciliation or truth effort that was funded by the philanthropic sector. There have been over 40 truth efforts around the world, but only in America has it come from the philanthropic sector to really drive this change. And people can get involved. They can visit the W.K. Kellogg Foundation website. They can reach out to us at the National Collaborative. We're working with organizations, we're working with communities, but we begin by creating a coalition of folks who represent some sort of expertise and leadership in all 5 of those pillars. And the work starts with sharing a vision for a healed America, a vision for an America that has faced and redressed our history of racial hierarchy. And only from that vision can we then move through the steps that are required for creating and actualizing that vision. It's exciting work, and we would love to partner with your community or your institution in some way. There is a network now of over, I think, 70 college campuses that are implementing truth, racial healing, and transformation campus centers as well. And that's coordinated through the Association of American Colleges and Universities. So that is a very important, timely, necessary work for our country.
You know, I just want to thank you for drawing attention to this national movement and how our campus could really become more involved with this, this whole concept of healing our nation. I just want to turn over to you, Dr. Robinson, and ask you from a major healthcare system right here in our area, how could your organization become more involved with our campus to lead an effort like this? And then also, what do you see as some of the challenges and barriers to health equity right now in our community?
2 big questions.
I know.
Well, so let me take the first one first. What do you want to do?
What do I want to say?
So in a lot of ways, we're already connected. I know that you're intimately involved with our medical school. You're part of an interprofessional association that actually is trying to figure out how do we blend our professions together, work more smarter. My goal is how do I get more of those folks into a public health workforce as part of a strategy. So I think we're moving in that direction. Dr. McAdoo cited you and potential pilots and have asked me to join in their evolution to create a public health element to that. And so I think whether you know it or not, we're going to be doing something probably very, very soon.
It's music to my ears.
Yeah, so, and then whatever else makes sense. I think there are a lot of opportunities for a connection. The founder of your PA program is a great ally and was a partner in crime in a charter school that I helped found. So we're already connected in a lot of ways, both formally and informally. The second half of the question is, I use the statement, you get what you design for. And the problem in terms of health equity and health care equity, those are two different terms.
Yeah.
The problem is our designs don't fit. So a real quick example. So within our ACO, we were providing food as medicine to young children in the midst of this pandemic. The rules allow you to provide food to the child, but not to that child's food insecure family. So I can be reimbursed for funding food for the child. The child lives within a family, but the reimbursement methods don't allow me to support the family or the friends of the family. The system is not designed to address population health or public health. It's designed to address illness. So when we change the rules for reimbursement, change the rules for how we deliver care, such that we deliver public health care, or then we moving towards equity. So we have a long ways to go because our system is not designed to deliver health equity.
Wow.
There's something wrong with some of that picture. You know that Tania, you are really involved in on the care delivery side. So, as you think about what Dr. Robinson just said, how does the individual provider begin to incorporate a public health approach to the way you provide care at the individual client level?
So to Dr. Robinson's point about the reimbursement, finding those ways to go around the reimbursement system, right? So, for example, going after foundation, dollars that become available. Prime example is working with the community foundation in Springfield. We received funds so that we could work with our teams, our community health workers, our providers, to distribute to the family and not having to worry about being reimbursed, but to make sure that the whole family is being taken care of, making sure that they have the food, making sure that they were able to social distance. They live in dense housing, and making sure that they sleep together, particularly the refugee population. Many of them were sharing the same beds, and being able to buy mattresses to separate them and place them in different quarters throughout the home. So working around the system, and it's sad to say that you have to work around the system, because if the system was correct, then we wouldn't have to go through these other ways of trying to find a means to make sure that the patients or the community is getting everything that they need in terms of food and other material things that they need in their homes. And you made a good point earlier about the lack of education or the lack of discretionary income. And Caring Health Center, as a community health center, we were founded by a community. So there was a bunch of community individuals that came together and felt that it was necessary and that it would be nice to have a community health center to serve the community. So 27 years ago, they came together And the funds didn't, because of funding constraints, they didn't get funded right away, but they continued to pursue the efforts of bringing in community health in the city of Springfield, which they did. And we continue on with the community for the community, making sure that we hire individuals who mirror our patient population, making sure that, and this could be individuals who don't, so our focus is not only on the providers, which Regina is sitting with me today, we love our providers, but I think one of the things that we're also missing is the support staff, the support teams, and making sure that they are adequately skilled so that they can be able to provide for their families. They, upskilling and upscaling and working toward a collaborative community effort. So working with Westfield State. Caring Health Center is looking, right now we're in the middle of looking to develop a learning institute that was recently approved by our board of directors. And this is uniquely different because with the Learning Institute, we're targeting individuals within the community that are switchboard operators, that are reception folks, and then once they get in the door, then they can change their career trajectory. Many don't know my background. I started out as the switchboard operator at Caring Health Center 25 years ago. So I started out at the entry level and then worked my way, going back to school, working my way up to the president and CEO of the company. I like to pay that forward and make sure that the underserved communities have that same opportunity to be able to become employed and be able to put food on the table and purchase the necessary means that just to live day to day and to be healthy. The health and then the health care systems that are available to our community. So,
I just love your story. Starting out at the switchboard and now the CEO. Did you all hear that?
yep.
Oh, yeah.
And Regina started out working
Yes.
at the Caring Health Center and now a provider of care. And I just wanted for you to share a little bit about the courage that it took for you to start out working as like a technician or a care provider at a lower level and being able to have the courage to move up. And I know Tania helped you to move in that direction, but just share a little bit about what it took for you to take that leap to want to go back to college, not only an undergraduate degree, but to get a master's degree to become a physician assistant.
Yeah, thank you. So as I said before, it was not easy. You have to forget about your weakness, about the things that you haven't achieved or the things that you are still working on it. For example, in my case, I was having a language barrier, but they saw in me that weakness was the strength to help the community. So as soon as they opened the way for me, they opened their doors for me, so I feel that support, and I say, okay, I have the support, I have the necessary support, so let's go. Let's do this. Let's do this. And when I came here also, my professor was, Regina, we are here for you. And even though there was a lot of applicants, we need you at the community. So if you open the doors for somebody that is willing to help, that is willing to learn, and is willing to get trained to help others, just open the doors for them. So you are now in that position. As me, there is a lot of providers coming from different other countries that didn't have the same opportunity that I had already. And it's so sad because they are here and they are not able to help others as the same way as we are now. So open the door for them, and as Caring Health Center already did for me, and also this program. Absolutely.
Sure. One of the things that I'm so proud about, and I just, Dr. Christopher, I just want you to know, is our campus, all of the faculty and staff on our campus are so committed to an equity agenda. Mm-hmm. And you could see the evidence of them just reaching in and picking out a diverse young lady and giving her the opportunity. And so, Dr. Grabowski, can you just talk about the way your school is so focused on helping lift up people to develop the future, to focus on going back into their own communities to help improve the quality of life and health outcomes.
Yeah, absolutely. So uniformly, our candidates to the PA program are excellent. Excellent academics, committed to healthcare. But what we really look for is, our neighbors in our community, people who live here, work here, have been raised here, raised their families here. Because the insight they have into local health disparity is just amazing. And this insight is incredibly valuable in determining solutions, to, the problems in our community. These are people who have, experienced healthcare disparity, either witnessed it or experienced this firsthand. So by selecting these candidates and putting them back into a place where they can help, where they'll have improved rapport with their patients are happier to see them, more likely to develop these trusting patient-provider relationships. It's just incredibly essential. When we look at health equity and healthcare disparity in this area, we think of quality of our healthcare as one of the drivers of social determinants of health. And that's really an aspect that we can help improve as a physician assistant program in our medical training. We think of excellent, providers and quality of care, and what does that really mean? As basic, it's selecting, the correct lab test or the correct antibiotic to prescribe to a patient, but it's really so much more than that. And our curriculum's really designed around quality as not just always selecting, the first most correct answer, but how to develop rapport with our patients that maybe aren't like us, that don't trust us, that need our help more than others. In creating a holistic view, centered on their goals and their healthcare views, creating therapeutic plans that really reflect those views and are accessible. You can prescribe the best care to a patient, but maybe they can't afford that care or they don't have transportation. So it's a lot deeper than just selecting, the best answer on a test. And that's what we really try to instill in our students.
So I want to kick it back to you, Dr. Christopher. And one of the things I just mentioned is we have a campus really committed to equity in all forms. And, I heard you talk about this Leadership Academy. I'd love for you to share a little bit with our community here how they might become involved or even apply, one. And then I know that you've had a passion for policy implementation. And then how do we move from the programs that we're offering, but how to influence more funding coming into our communities to really develop the future and to improve outcomes for communities?
Well, thank you for the questions. I do want to respond to the comment about the mismatch between the systems of funding, which leads me to answering your second question first. The potential mismatch between the systems of funding and what is needed by communities. The story you told about the food and not being able to provide the food for the family, but only for the child. And there are many examples of those types of policies that were created by people who are very, 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 very far removed from the realities of what communities deal with. And so this notion of having an intermediary like the community health center, like the other programs, the physician's assistance programs that embodies the diversity and the lived experience of the community. This is a step, but we also have to translate that into our ability to advocate, really, for the policy changes, because the decision to decide how the funds are allocated, that's a policy decision. We in the DC area where I live in Maryland, and we're kind of a combined community, but we just had a successful story today about how during the pandemic, there's a program called Thrive DC, and they actually gave a lump sum of money to families. They gave over $5,000 to families with no restrictions. The heads of households could use that money as they needed to use it. Now, initially, that pilot was funded by a philanthropic organization, not unlike the story you told of getting around the restrictions by going to the community foundation, by going to philanthropy. But it was so successful in terms of the well-being and the feedback from the families that they're going to turn that into a policy for this city. And so definitely the policies are what we have to advocate for. They're what we have to show because, and again, it takes us back to leadership. By all means, we have at this stage, we're in a pilot for this model that we're going to bring in for 18-month period of immersion. And so probably 14 months into that, we're going to have a new set of applications, and you can visit the National Collaborative website and apply. My dream is to grow that leadership experience, almost exponentially, because we want people to be able to be part of a national network and movement, to feel connected, and to be in their communities with a great deal of determination to not only meet the needs of the underserved or the communities that have been traditionally marginalized, but to end the marginalization, right? And to enable us to really come together, to build coalitions, to stand in solidarity for what we know is right. And we know that our lives matter. We know that our lives have equal value. And so we have to help folks to understand the nuances of advocating for policies. We have a product that we share. It's on our website. It's on the American Public Health Association website. It's called Healing Through Policy. And it's a collection of 5 briefs that parallel that framework I talked about earlier. But it gives examples from around the country, evidence-based examples of what communities are doing to change policy as part of driving new narratives, as for building better cross-racial relationships and solidarity. In the state of Illinois, for instance, they put out a large grant and made it available across the state to support racial healing efforts in that state, to bring the urban and the suburban and the rural communities, to create opportunities for people to come together and have meaningful dialogues and whittle away at the fears and the prejudices that we have. So I really encourage you to download the Healing Through Policy briefs. There's just a panoply of policies that are recommended within those briefs that communities are doing. And we are starting, I believe in May, we're going to launch what we call a community of practice or a peer support network, where those communities that we identified in the briefs that are doing the creative policies, they're going to be able to partner up with communities that want to do the work. So that's another potential opportunity. And we're going to support this peer network where we kind of call them like sister communities, so they can help each other to implement these creative new approaches. In a democracy, it's really up to us. And we have to learn that civic engagement is a requirement if we're going to actualize our democratic tenets that all are created equal.
I just love that last comment that you made. I just want to let our panel just share briefly some thoughts before we move into questions. We have some questions that were already developed by our audience, but I'll just start with you, Dr. Robinson. Just share whatever thoughts you might have on this whole issue about health equity, and policy from your perspective, from your institution.
So I'm going to answer the other question you had around working together as well in this answer. So I've been involved over the last 2 years with establishing what we call an anchor collaborative, and that is a collaboration of anchor institutions, Baystate, Big Y Business, Comcast, Bay Path College, Holyoke Community College, City of Springfield, City of Holyoke. The ideal being, if we work together as a collaborative, purchased goods and services, hired local diverse talent, made place-based investing, and if we targeted those resources for low and moderate income neighborhoods and communities, that the money that we talk about needing that already exists here, if we spent it differently, you could actually create healthier places. And so I am inviting Westfield to join the Anchor Collaborative and hire, supply, purchase goods and services locally, and do place-based investing, stuff that you're already doing, but let's do more of it.
Sure.
And for me, that drives us towards equity because we get to change the conditions that people live in. We don't necessarily have to continue to tinker with the odds, making it easier for people to live healthy. We actually change the conditions that creates health. So it's that kind of investment. So Baystate spends $450,000 a year on goods and services and contracting and whatnot. Give me 1% of that and just spend that locally. And if we did that across all the anchors in the Valley or in Springfield, we could really turn our communities around, create equity and health. So that's my big ideal.
Okay.
And so join us.
Sure, I'll be happy to join
Okay.
join you on that effort.
Hey, great.
I have some people in the audience who want to join you in that effort too.
Good,
So
great. Fantastic.
I really appreciate that comment. Tania, one of the things, I've been over to your healthcare center and I just loved it. And, I just want to give you an opportunity to also share with us, with the audience, your perspective on how our two organizations can partner to improve what you do.
Sure, thank you. So again, I can't agree with you more, Dr. Robinson, in terms of investing in our local community. One of the things that Caring Health Center, I always like to say intentionality. We have to be very intentional about what we do. And to Regina's point earlier, allowing people the opportunity to return to school. That's one of the things that we do very well at Caring Health Center, flexing, allowing people the opportunity to return to school, and then fortunately having the opportunity to bring them back in because they're from the community and then they're serving the community. So I think that is really essential in the ways that we can continue to partner. We're partnering with the Physician Assistance Program, but as we work toward our Learning Institute, we can certainly partner, whether it's certificate programs or accreditation, credits for these individuals, because again, it starts with helping our community. And at Caring Health Center, the other thing is that many of our staff mirror our patient population. So a majority of our executive leadership is BIPOC, it's a BIPOC workforce, and the majority of our staff also represent or is reflective of our patient population. So we hire from the community. So we hire not only from the community, but we hire our patients. Our patients, refugees. Refugees come in the door. They come in for a first and second refugee visit, not knowing several years later they're going to be employed by Caring Health Center. They're going to be a community health worker. They're going to be an interpreter. And they're going to be able to advocate for the community to help them be able to turn their lives around. And being able to work with universities such as Westfield State with the programs for whether it's community health programs, community health worker programs, or the physician assistant program, or simply the frontline entry individual who doesn't want to work at McDonald's. They have aspirations and dreams. They want to one day become a medical assistant and move from a medical assistant to become a physician assistant or a nurse practitioner. How can we collectively work together? And there's definitely ways and opportunities that we can work together. There's many people, I myself as an example, have aspirations and dreams. Didn't always want to remain a switchboard operator. Wanted to, the leadership that Dr. Christopher spoke about, the leadership opportunities, being able to have the resources and the tools and help people to navigate a system that they don't know how to go about navigating it. And then working together collectively in a community to help people rise to what they're aspiring to become.
Sure, to reach their ultimate dream or their goal.
Yes.
And I just salute that effort. And we want to help you with
Yes.
that Learning Institute, don't we?
Yes,
We
yes.
really are interested. So I just want to allow you, Dr. Grabowski, to share any final thoughts that you want with the group about the program, the approach, and how we can get more students involved in supporting health equity.
Yeah, absolutely. So I know we have a long ways to go locally, nationally, even as a campus, but I'm incredibly proud of our program and our success. When I look at somebody like Regina, you know, she's part of the solution to all of this. You know, so I'm so happy that she agreed to come with us and work with us and stuck with us through, you know, a difficult medical curriculum. You know, so I think by engaging, you know, our prior graduates in conversations like this, having her come back, you know, as, you know, a teacher for our program and talking about her experiences and what it's like to be, you know, a medical provider who's English as a second language, who came from a different country, you know, who doesn't represent the majority, you know, of the population, you know, is incredibly valuable.
Mm-hmm.
So let us know what we can do,
Sure.
you know, to work with you.
Well, Regina, one of our goals on our campus, I don't know if you know this, is to become a Hispanic serving institution.
Perfect.
You know that, right?
Great.
So, you know, how would you help us in the community to reach back and recruit and get more people on our campus who think like you, who look like you, and who want to have an aspiration? What is it that we need to do more of? What do we need to change, and how do we do a better job with getting more people to choose Westfield State as the institution?
Just keep your doors open. Soon as I finish the program, you can imagine I have been receiving calls from Boston, people from different areas calling me how I was able to do this. So, and I have been sending them here. I don't know if Jessica, you have been receiving any requests, but
Yes.
a few providers coming from different countries, and they came here and they are trying hard to start over again.
Yeah. Mm-hmm.
And if you keep your doors open and here to help to, you know, to connect those people, we can continue preparing and develop policies in order to, you know, to train and then to be able to help others. Mm-hmm. Absolutely. And big changes start with a small step. So here, step by step.
Small steps,
Small
right.
steps.
That's great. Well, I know we had a large number of questions that came in before we started. I wanted to, you know, to turn to some of those questions from the audience. So the first question I got was, what can Westfield State do to make a difference on campus, in the city, the state, and nationally? I mean, that's a mouthful, right? So I'll let our panel respond to that very expansive question.
Well, you know, I would say you're doing it. I mean, it's such a privilege for me to listen to the authentic narratives and the clarity and the strategic vision and commitment that you're demonstrating right now. I guess the only thing I would say is amplify that, you know, make sure the world knows this amazing organization, this amazing institution, and all of the things that you're currently doing creatively that are a good model for what everybody else should be doing.
I want to thank you for saying that. What are your thoughts?
I think it's being present in Springfield. I'm going to be parochial for a bit. being present in Springfield. So when I go into a room, when they lift we go into rooms again. For regular meetings, they have Westfield as part of the conversation. So I think before you came, Westfield was absent from my life, from my work. I've heard more about Westfield recently than I've heard in many years. Mm-hmm. So what I tell folks that I work with is, if you're at the table when we're making the decision, we're cooking up the deal or we're designing the initiative, then you have skin in the game. You're part of that solution. If you're not there, it's not like we don't want you there. It's just that we're moving so quick towards a goal that we don't have time to reach back and pull folks along with us. So I think to the extent to which Westfield is present and evident, I think I can't say anything simpler than that. It's a good small step, but I think there will be big dividends on your involvement and engagement.
Okay, well, I'll always bring my chair to that table.
All right.
All right, Tania?
I actually agree with Dr. Robinson, and I think that Westfield State has already taken a step in the right direction by recruiting Dr. Thompson. So I think that's amazing. And then having these kinds of forums, right, to make a presence within the community. And again, because Jen, who helped to start up the Physician's Assistant Program, she actually reached out, and that's how we, kind of started engaging in Westfield State. But prior to that, we were working with all of the other schools, and then Westfield State was kind of, out of, the picture. So I think to Dr. Christopher's comment, I think it's already begun.
Yeah.
And to continue to have that presence, and seat at the table and pulling others in the community from Springfield and the surrounding areas, and, having them to have a seat at the table also, I think you will do well, and you've already begun the process. So.
Okay, I appreciate that. Any thoughts from you?
Oh, for an expansive question, I guess I can only give a simple answer, but to continue to identify areas that, need help and focus in our community, to acknowledge areas that we need to do better in, and just continue to, keep doing our good work.
Regina, any thoughts on that?
Yeah, and the fact that we are here having this conversation is like you are going in a really good direction, right? Involving the community and having this, discussing these important topics for all the community. Absolutely.
I appreciate that.
Yeah.
So we have another question. Why is it important that we collect race and ethnic data from community health center patients?
Sure, says the person who has a research department. It's critical that we are collecting this data because, again, it informs best practices. It allows us the opportunity to understand what's taken place in the community and what our communities need. For example, collecting data through focus groups, we were able to create programs like, for example, a wellness center. Caring Health Center created a wellness center. We're expecting our patients to change in terms of diet and exercise, modifiable behavior change, but transportation barriers, they can't get to, or financially, they can't even afford to become a member of a local gym. So bringing that to the patients, so collecting that data, understanding the areas of need, we were able to bring a wellness center to Caring Health Center. And then medication adherence. Folks are coming in from other countries. They don't understand Western medicine, but being able to have focus groups and understand and collect the data, what the needs are, and to help them to manage their chronic illnesses and comply with the medication. So it is very critical. And we can't make assumptions. We can't just look at an individual and automatically assume by their appearance they might be from one race, one culture. So really, truly understanding so that we can better serve the community and provide the care that's needed for the community. So it's very critical that we collect data. Behavioral health, that's another program that we implemented at Caring Health Center. We didn't have that. Pharmacy, medication therapy management, MAT programs, all of this was derived on getting data from our patients, again, to see what the needs of the community was, and is.
Let me just add a little bit to that. What COVID revealed for everybody, health and healthcare, was the fact that we didn't have good data. When we tried to do precise targeting of messages and identify areas of need, we went to the data, and the data was vanilla. everything was sort of all mixed in, not stratified or disaggregated by race, ethnicity, language, disability, SOGI information, sexual orientation, gender identity data. So we didn't have that. We still don't. And as a consequence, we missed a lot of opportunities to really help people and serve people. And we created, exacerbated inequities that already existed. So by stratifying data, by using data to be more precise and more targeted, we, one, can reveal inequities and disparities, and we then have the information necessary to take action to close the gap. So Baystate this month has delivered its first ever objectives, annual objectives stratified by race, ethnicity, not language yet, but race and ethnicity, to begin to understand how we improve quality, because there are health care disparities. Disparities happen within the healthcare system, and if we don't know about it, we can't do anything to close that gap. In addition to health disparities that are broader disparities for the overall population. So again, stratify the data, we can then design solutions to address specific gaps.
Can I just add to that? It's real quick. I was just going to say also sharing the data, right? Because if you have a hospital system that's, you know, looking at data, and then you have a community health that's looking at data, but there's no sharing of data, that's really critical too, to impact the care needs.
I would just like to add, I agree 100% and support everything that's been said. If we could get people to understand that the story that we believe, the story that we hear is shaped by the information and the data that we have. And so if we're going to heal our country, if we're going to prioritize and redress the challenges, be they in the healthcare system or in the community, we have to have the data that's telling a true story of what is going on and what are the needs. So data is a basis of narrative, and I think we can't lose sight of that in our work.
I just agree with all of that you said. I know when I was on the National Institute of Health Advisory Council, we were looking at the data that they lump Asian populations all together, but we were seeing these pockets of people who had disproportionate health outcomes. And so when you broke up the Asian population and you looked at Chinese, Indians, Koreans, you know, when it was disaggregated, you really did see the disparities that existed and some of the issues. So data are so critical to be able to provide the right care based on what you see. Many communities of color have had negative experiences with the medical community. How can that trust be rebuilt? That's a mouthful, right?
I'll dive in because it is not a simple answer, you know, but the emphasis, the stories that you shared this evening about making sure the workforce is a reflection of the community. You'd be surprised how quickly people make a decision when they encounter a provider as to whether they think they can trust that provider or not. And when they see themselves in that provider, that is a step toward creating the opportunity for more trust, but also educating providers, no matter what their race or ethnicity or background, to have the skills for developing the rapport with the person in ways that, you know, we just took it for granted that, you know, you're the authority figure, these are the patients, and that just doesn't fly anymore. I mean, you really have to have the skills for compassion, for empathy, for rapport establishment, for communication, and we've got to build that kind of learning. I love the Learning Institute that you're developing. We have to really become, you use the term intentional. We really have to become intentional about building these capacities, particularly in a society that's grounded in a history of racial hierarchy. So how do we build the trust? We develop specific strategies and learning opportunities and ways to model and practice building the relationships that are grounded in mutual respect and regard.
Dr. Robinson, do you want to tackle that question too, based, from a, you're in one of the largest healthcare systems, and I remember one of my, someone I knew in Baltimore wanted me to go with her to a hospital because she said, you go down in that basement, you never come out.
Well,
Yeah. No.
so I'm not sure. There are a lot of different ways of approaching it. So I was on a panel yesterday. I moderated the panel at Baystate, and it was around Black men's health. And in setting up for that panel, we talked about our experience. And one of the points we made was that the health systems and the systems in general that we walk into aren't always inviting. In fact, I shared my example. I just hope this doesn't get me in too much trouble. So if I have to go to the emergency room at Baystate, I put on my uniform. If I show up in my sweats and my whatever, dressed down, I'm going to get a different kind of treatment. So I put on my uniform. And that's not with Baystate alone, but it's with other institutions. So how I present myself, the uniform is a bit disarming for them. They don't necessarily see me only as a black man. They see me as a black man in uniform who maybe he knows something because he has a uniform on. So our healthcare systems are challenging places for people, and even more challenging for people of color. Because there is an inherent or a built-in or an implicit bias that operates. So to Baystate's credit, pre-pandemic, we put together a structural inclusion process. We're in a process of doing structural analysis and looking at the disparities in employees by race within our healthcare system at all levels, with a commitment to change programs and policies to create a workforce that is more reflective of the population of patients we serve. Good news, it's hard work, and folks are struggling to understand how to do the work, because it's new work for our institution. So again, that's sort of, as I listen, I sort of got the question. I'm not even sure I'm responding to the question. I got lost in the thoughts as I was listening to Dr. Christopher. But that's my comment for what it's worth.
Sure. Do you want to add anything?
I think they both stated
They've answered the
they
question.
answered it very
Okay.
well. One of the things that we recently did at Caring Health Center in really recent November, so while you think you might be further along than you really are, when you start to really delve into it, you find that there's still room for improvement. And so November, we hired a Chief Access and Equity Officer so that we can look at our policies and then we can look at our current employee structure. And while we're very diverse, there is opportunity to educate and teach on cultural humility and cultural competence and healing racism. Those opportunities still exist. And because, you think that you're further along and then you just find like, okay, we still have a ways to go. So it's the ongoing training. And then when you educate and you teach the employees, then hopefully they'll be able to build that trust again, with the patient population. And again, to Dr. Christopher's point earlier, having individuals that look like you, that you can come in and you can really, the person may have walked in your shoes before, and so you can really, engage and communicate with them.
What measures can health centers develop to reduce preventable diseases such as diabetes?
So as a community health center, prevention, wellness programs and services, Caring Health Center, we have a chronic disease management department that focuses on diabetes. I just literally had a conversation with our one of our diabetes specialists, and we talked about that, and we talked about an individual who recently was hospitalized because they're struggling with some challenges related to diabetes. And how do you, so we're having this conversation, and how do we encourage individuals before the disease even presents itself, you know? And again, we're looking at ways to measure that. We actually, our quality department, quality improvement department, the clinical measures that we have in place are ways that we can look at the different patient populations, like who has more high instances of diabetes, who more prevalent to the disease, and then working with that population, reaching out to that population and trying to really get them in again before the disease. Now that's kind of hard because folks don't really want to come in if they don't feel that there's anything wrong with them. So, how do you educate individuals to say that, prevention is really critical, is really important. So we are, as a community health center, we're expected to look at that, so I think there's a little bit difference because we're federally funded, and to get our dollars, we have to write in all of our clinical measures that we're going to focus, that we're going to look at, and not only do we have to write it in, every year we're measured by that. Annually, you have to write the performance and the benchmarks, and if you didn't meet that, why didn't you meet that? And then what are some of the strategies that you're putting in place to mitigate that? So it's expected of us, but again, there's always room to grow.
I know that
I would love to weigh in briefly. I think that, first of all, I just wanted to say how every time you describe the name of your center, caring, it's a verb, it's to do, it's to care. It just makes me smile. It's not, just a health center, it's a caring center. And everything that you said reflects that caring. We can't separate the issue of food and access to food, of movement and access to safe environments for movement. We can't separate how we live from the vulnerability to metabolic syndrome and to diabetes. And so when we talk about measuring, this is a wonderful place to think about the intersection between our discussion of the conditions that promote health and well-being, as well as the diagnoses and the pathologies. So we need to be measuring the access that people have to nutrient-dense foods rather than, almost exclusively high-calorie, nutrient-poor foods. And this became so evident over the last couple of years as we looked at the impact of the COVID-19 pandemic. So making sure that here's a case where measuring the conditions in which people live and the opportunities that they have to be in relationship with their bodies in ways that promote fitness and health and well-being. We've come a long way in the last 50 years, and we can no longer ignore, the dietary components, the nutritional components, the movement components. I use movement because exercise scares people, so I say movement. We have to be realistic about muscle mass versus body fat, and make sure that we're getting people to understand and be empowered to take control and have a relationship with their own bodies that are grounded in a sense of love and knowledge and understanding the power that we do have, So I concur, and I think the community health centers, as I said before, are the best kept secret of our healthcare system in this country. But we really have to go out of our way to apply an intentionality around measuring that whole continuum of factors that leads to the vulnerability to diabetes and to the chronic diseases that are also associated with that.
Yeah, Dr. Christopher, you were in my life about 15 years ago at Kellogg.
Really? Say more.
Yeah, we had a grant from Boston Public Health Commission. It was a REACH 2020 grant.
Yeah.
We drove from Springfield to Boston regularly for $25,000. I don't even know, it was such little bit of money. But But the consequence of that grant and that association spawned a food justice initiative in Springfield.
Well, there you go.
And
I
as
think I remember this.
a consequence, there's a ordinance, a city government around, and there's a food policy council. There is a urban garden run by youth. We tried to establish a supermarket, and we failed miserably. It's not we won't do it soon, but we failed miserably. But there's this intense food justice initiative with community campaigns, and so this notion of preventing diabetes, you get ahead of it, and you organize it, and people involved in their own education, their own understanding, and you provide those resources that are necessary, walkable streets and access to food, et cetera, et cetera. So, and you started that.
So I am just so happy to meet you, Dr. Robinson, although I think we met before, right?
Yeah, I think so, in Boston.
But to hear of the wonderful work and the cohesion in this community, it's really been a pleasure to be involved and to listen to you all tonight, because you know, this is the good news. I spent all day hearing about Ukraine and Russia, and you know, it was a bad day, you know, but I'm so happy I've had the opportunity to end my day on such an up note in terms of being reminded of what we really can do and what we stand for as people. So kudos to all of you.
Yeah, well, I just want to piggyback on what Dr. Robinson said. You know, we're kindred spirits, and our public health backgrounds and the leadership of Dr. Garrity.
Yep, we share
a mutual mentor who helped me get one of my first research grants funded. So, you know, any final comments that each one of you want to make before we close out? So I'll start with you, Tania.
I just want to say thank you for the opportunity, allowing us to come together to talk about such a very important topic. And Dr. Christopher, thank you for your wisdom and your knowledge. And obviously the work has begun, but it is clear, as you see, we still have a lot of work ahead of us. But the good news is that collectively we are all working to get there. So thank you.
Final.
And I thank you for Dr. Christopher as well for your words and the reconciliation process that you described. Boy, do we have a home for it here in Western Massachusetts. So we're going to do something with that.
Good. Any final?
Absolutely. Thank you for having us. I'm just really reassured that so many people care so deeply about the health of our community, and I just hope that we can continue to do better.
Final comment.
Thank you so much. It has been an honor, and thank you for having this type of conversation.
Any final comments, Dr. Christopher?
I'm with everyone else in expressing my heartfelt appreciation to you for your leadership in bringing us together. And I really think it's so important that we maintain our commitment to holistic approaches, understanding that health is the natural state, that a body that can create itself can certainly bring to bear so many forces for healing and for sustaining well-being if we create the environments and the conditions that allow that to be fully expressed. And it's clear that you all are doing this work there and stand as a model. And I hope that this is not our last conversation. I hope I have a chance to stay engaged in some way over the years.
Well, you know, I always try to get you engaged anywhere I am, so so you can't run too far from me. So I want to thank each of our panelists today for the insight and expertise they brought to our conversation. I'm deeply grateful to each of you for your participation. I also want to thank those in the studio audience and online who asked such thoughtful questions. For those of you that know of others who might have missed this conversation, a link will be available on the Investor page of the Westfield State University website. I invite you to join us for our next community conversation, which will take place in late March. That conversation is titled Equal Rights and Justice in a Challenging Season, Honoring the Humanity of All. This will be part of a much larger symposium taking place on the Westfield State campus. I expect it to be a very thought-provoking discussion. Watch your email for further details on registering, and please remember that links for all community conversations will reside on the investiture page of our website. So thank you.